We could always edit it,
Edit.
this
Yep.
part out, yeah.
That makes sense.
I don't know how many meetings we say, oh, we gotta start the recording, and then it's like 10 minutes into the meeting, we start the recording.
Right.
Hi, Vanya. Vanya is joining us from AG.
Hi,
Perfect.
Laura. Hi, everyone.
Hi, Vanya.
I'm going to step
Let me
away
know
for
if you
just a
guys
second.
need any
okay?
help with anything.
Thank
I'll
you.
be here. You're welcome.
Will do. So you have a transcriptionist? Go ahead, David. Just do whatever you got to get. We'll hold down the fort until you come back.
All right, thanks.
So you have a transcriptionist, you were saying?
Let me confirm that, David. But we're recording this right now, right?
We are recording.
And it will be
yes.
recorded. All right. Let me confirm that we should. It's in the what's it called? Work assignment, but we should. Let me double check.
So I clicked record. I'm not sure if it will show up on my computer or will show up on Laura's computer or.
It'll show up on your. It should show up on yours. It'll be in the chat after
Okay.
the meeting.
Got it. And then I'll send that to you guys.
Yeah.
Okay.
Afterwards.
Sounds good. Thanks, David.
I'm just looking for names in the till we can let people in.
And if I chat, can I chat to people in the lobby?
It's meeting chat.
Okay. Because we have 157 in the lobby as of right now.
Yeah.
And we haven't even started yet. So no pressure on David. They're all here to see him.
Yeah, I know Stephanie is out for the week.
I'm trying to find any email that indicates anything about her ordering a transcriptionist to attend.
It was in one of the emails. But
Okay,
if we have
good.
the recording, then the transcriptionist should be able to get it on the tail end. Because what we ultimately want to do is we want to get the presentation that David's doing in a 508 version that we could put on SAMHSA YouTube and then have a link from our samhsa.gov page to the YouTube, because I think this would be helpful to those that are trying to understand the criteria, and it would be a nice little addition to what we've done, what we have on the web page.
Right.
Yeah, Vanya, there were people from AG forwarded. They got the invite forwarded to them. One was Catherine Wilson.
Oh, okay. She's one of our project evaluators. She's probably just here to attend and observe.
And Peg Anthony.
Oh, yes. That's our Peg.
The other thing is that we will have transcription, through the system, so they can always use that file as a way of starting. Just the error-prone Microsoft transcription. So.
And I think Elizabeth Caseta. But
yeah, they're here to observe or to attend, I should say.
Okay.
Thank you.
So I think we're okay with we'll get a good transcript out of this, and I think we'll get a good recording as well. Just as long as David, you'll have to remind people at the beginning that this is being recorded, and if they want to jump off because of that, they can if they want to.
Yep. Sounds like a plan.
But you've got now like 281 people in the lobby.
And we're not even at 3 o'clock yet. Well, last time we did something, we were at we had a cap of 500 and people could not get in.
Right.
Is this just our regular Teams platform?
You have a capacity of I think it's 1,000 here in this Teams.
Okay.
And that's people who have like a full functionality of they can do the chat and all that stuff. After that, I think it's 10,000, but they don't have all the functionality. They can just view and listen.
Okay. Wow. All right. Well,
I don't think we'll be getting that.
As the way I understand that this version of Teams, Teams for Government is a little bit different than the full blown we pay for everything Microsoft Teams. So And not every application is FedRAMP approved, which this version of Teams apparently is FedRAMP approved. So this is, Teams. So I think you'll be okay. You're not doing anything too crazy.
Great.
So it's 3:00. I have to jump to my other meeting, but I
Okay.
think you guys are okay. And you can admit everybody in the lobby if you want when you're ready.
Yep, you'd let me know, David.
Okay. Well, I am. Let me just share my
Um,
screen just to make sure I'm doing it right. I thought that I don't do this every day, but this is what it'll look like. Is that good? Can people see?
Yes.
Yes.
Okay. All right. Great. I'm gonna stop sharing and I'm gonna do that again when
I
it's
think
time.
I'm gonna go off camera, so this way it's
Okay.
you and your slide deck. We're at 257.
Okay.
It looks like we're kind of leveling out here.
All right. Well, I'm gonna hit admit all. And we can
Go
let
for it.
people in and get going.
Okay, good luck, guys.
Thanks.
Oh, that's gonna be interesting.
Hey, everybody, we're just going to take a couple of minutes and let people join. Just so you know, today's meeting is being recorded. So if your camera's on or if you say anything, it's going to be recorded for posterity. If you have a problem with that, take care of your camera, don't say anything, or you can always sign off if you want to catch the recording later. So, but we are going to be recorded today. We're just going to hang on for a couple of minutes as people join. Thanks so much. There's some comments in the chat that people are having trouble joining. This should have capacity of at least to 1,000 and perhaps beyond that. So there shouldn't be issues. If you can just encourage people, if you're in contact with them, to keep on trying. We're going to be letting people in as we're able.
David, I had a couple people from Nevada.
Sorry, Joseph, I think I accidentally muted you.
Yep. Can you hear me now?
Yep.
Oh, yeah. So I had a couple people in Nevada that were having trouble getting in, and I just invited them over on the participants panel on the right side, and they were able to get in. So if others want to try the same thing, that might work for them.
We should have 1,000 capacity, which I think will get us through this, but hopefully we won't test that. Well, hopefully we will test that. I'd love to have as many people on as possible, but hopefully we won't
I
have
think that
anybody.
I think within Teams, there's a limit for how many could be in the lobby.
Yeah.
And people are getting an issue with too many people in the lobby. That was the message that the two people from Nevada were getting.
Well, we're trying to hit the admit all button as many times as possible to get people in. So hopefully we'll get people in. All right. Well, we are 5 past the hour, and so hopefully we can just get started. Although, can other people hear this message of announcing people joining?
David,
Okay.
yes, unfortunately, the owner of Teams that just departed is the only one who could mute that.
Okay.
So
All right.
I'm gonna reach out there, see if she could jump on to do that.
Okay. Well, I'm going to try and start presenting, and then we just may get interrupted while people join. So, all right. Okay. So first, thanks to everybody. Really appreciate. I know you're all busy, and so that you're taking out some of your time this afternoon to be with us to learn about the certification criteria. It means a lot to us, and we will try and be efficient and use your time well. I said this at the beginning, but I'll say it now. We are recording this meeting, and so if you have an issue with being recorded, you can either stay off camera and not share anything verbally, or you can wait for the recording. But we are going to be recording the meeting today. And so today I'm going to be talking about the updates to the certified community behavioral health clinic certification criteria. And just bear with me for a second while I share my screen. Oh. All right. Okay. All right. So thanks everybody again for joining. We'll jump right in. So today I'm going to give you some brief general updates about the status of the CCBHC initiative in general. I'm going to and then I'm going to talk a little bit about the growth in the CCBHC program and the timeline for the CCBHC program. I'm not going to go over the updates to the certification criteria in a lot more detail. And then I think we're going to have time for 10 to 20 minutes of questions at the end. Looking forward to hearing your questions. So we're very excited. There's been a lot happening in the world of CCBHCs in the recent history. We have been lucky to have growth in the CCBHC model. Just in 2017, we started out the CCBHC initiative with the beginning of the CCBHC Medicaid demonstration. And at that point, there were 67 CCBHCs across 8 states. Between the Medicaid demonstration, I think someone stole the control of the team screen from me. I'm gonna take that back. All right. So so we're now at the point across the Medicaid demonstration, the SAMHSA CCBHC expansion grant program and independent state programs. We have more than 500 CCBHCs across 46 states, the District of Columbia, Guam, and Puerto Rico. We are very excited. We just announced the addition of 15 states to receive planning grants, which are going to be necessary to join the CCBHC Medicaid demonstration. And those states are listed up here on the screen. That's a very exciting development for us. The second thing that is nice is today we are announcing the another round of grants for CCBHC expansion grants. They should be going up on the SAMHSA website. So there will be more opportunities for clinics to get funding to support the CCBHC model. But this map kind of shows the spread of CCBHCs across the country. So this is a timeline of the CCBHC initiative to date. And you can see that the CCBHC initiative was initially authorized by Congress in 2014 through the Protecting Access to Medicare Act of 2014. In 2015, we released the original version of the certification criteria that govern the CCBHC program and define what it is to be a CCBHC. In 2016, we selected 8 states out of 24 that received planning grants to join the CCBHC demonstration. And in 2017, they started that demonstration program. In 2018, we awarded the first 52 of CCBHC expansion grants that SAMHSA awarded. And we've been lucky to have increases in the funding to that program every year since then. And now we have over 450 organizations supported through CCBHC expansion grants from SAMHSA. In 2020 and 2021, we added 2 additional states to the CCBHC Medicaid demonstration. In 2022, we had a very exciting development through the Bipartisan Safer Communities Act, which expanded the Medicaid demonstration and extended the Medicaid demonstration through 2026. And so, just a lot of growth and movement with the CCBHC initiative. We also realized that as a result of the expansion through the Bipartisan Safer Communities Act, that it made sense for us to update the certification criteria, because if we were going to be adding new states to the demonstration, and we knew that we needed to update the certification criteria at some point, it would be important to update the certification criteria before the certification criteria, before the additional states were added to the demonstration. So in 2024, we are going to be adding 10 additional states to the demonstration out of the states that have received planning grants. In 2025, we'll be announcing another round of 15 planning grants for states. And in 2026, we'll be adding an additional 10 states to the demonstration on top of those that are already participating. And our current authority is to add 10 more states after that every 2 years. And so, we're on a path for future growth in this very, I think, promising model. And again, I do apologize if folks can hear the announcement of people joining. It's a little distracting on my end, but I can hear a lot of announcements of people joining the initiative, the meeting today. All right, so charging ahead. Okay, SAMHSA and the federal partners have been considering updates to the criteria for some time. And the passage of the BISC, as I just said, made that something that we needed to do. And there are several reasons why we felt that we needed to update the certification criteria. We're committed to the CCBHC model, and we think it's a solid model. But there are several areas that the criteria do need to be updated. First, we need to respond to developments in the field, such as newer terminology that's being used in the field. There's been so much work done around crisis systems and 988 systems over the past decade, culminating with the rollout of 988 nationally. There's a lot of emerging best practices across the field, and there's newer conditions. We are in the midst of, I think, historic workforce shortages, and we wanted to recognize that through some flexibilities in the criteria to respond to that. There were also several sections of the existing criteria referred to Office of National Coordinator regulations around electronic health records that were no longer in place. And so that is certainly something that we needed to update. Finally, we had to we wanted to address areas that have been suggested over the years for improvements by CCBHCs, by states, and by other stakeholders, such as increasing our focus on substance use disorders and addressing social determinants of health. So the structure of the criteria is laid out in statute, and this is the structure of the existing criteria, and it will continue to be the structure through the updates to the criteria. And you can see here that there are 6 broad program requirements around which the criteria are structured. Those are staffing, the availability and accessibility of services, care coordination, scope of services, quality and other reporting, and organizational authority and governance. And really the bulk of that 4th area, the scope of services, lays out 9 required services that CCBHCs have to deliver, either directly or through a formal partnership with a designated collaborating organization. And so those 9 services remain in the updated criteria. Those 9 services are crisis services, outpatient mental health and substance use services, screening, diagnosis, and risk assessment, person and family-centered treatment planning, psychiatric rehabilitation services, community-based mental health care for veterans, outpatient primary care screening and monitoring, peer family support and counselor services, and targeted case management. So we've been going through an extensive process to update the certification criteria at the federal level. So we, in November of 2022, kicked off the process by soliciting public and partner input. We had calls with over 15 different groups, including federal partners and stakeholders. We held a 4-hour listening session for the general public, we had a kickoff webinar describing our process. We also accepted written feedback from a number of groups with a deadline of November 21st. We took all of that feedback and we developed a version of the draft criteria, which was posted for public input on December 21st. We had a webinar to the field to educate people about the draft criteria. We did that on January 5th. And then we had separate webinars with states to get state input on January 17th and 19th. We had a deadline for public comments based on the criteria we posted on the draft criteria we posted on the 21st of January 20th. And we got pretty extensive written public comments based on those draft criteria. We received comments from over 130 organizations and individuals, including several states listed here on the slide. I'm not going to read them all out, but we got really great feedback from our state partners. We also got feedback from a number of stakeholders, also listed out here on the slide. Again, I'm not going to read through all of these, but a lot of feedback from a solid group of stakeholders. We got a lot of feedback from individual CCBHCs, which we really appreciate. We got a wide variety of valuable feedback based on the experience of CCBHCs. We also got feedback from other organizations. A couple of consulting groups wrote into us with input. Mathematica, who is the evaluator for the Medicaid demonstration of CCBHCs, provide us with their input. We had input from other groups like the NetSmart, the National Committee on Quality Insurance, and the Joint Commission. So a few other groups beyond our traditional stakeholders weighed in. Beyond that, we got a lot of really good feedback from individual practitioners, experts, researchers, and advocates. And so really happy to get that broad feedback. And I think they really helped us to strengthen the criteria. So for all of you who are on today, who submitted feedback, I hope to see it reflected in the criteria, and also just appreciate the time that you put into that, because I know you're all busy. So we posted the updated criteria last week on March 16th. And today we're having our final webinar on the overview of changes. I will say, we are working in developing our CCBHC technical assistance nationally. This isn't the last you'll be hearing about the criteria. Today, I'm primarily going to focus on changes to the criteria, but moving forward, we're going to have more in-depth opportunities for people to learn about what exactly is in the total criteria as they've been updated. So where do we make revisions? We've tried to group it into 3 major areas. So there's significant updates to advance the field in 3 major areas: around crisis care, around responding to the overdose and substance use epidemic, and then addressing health equity. We've also made revisions around other necessary structural changes to the criteria, increasing the flexibility and reducing burden within the criteria, making additions that strengthen the model, updating language and examples throughout the criteria, and then clarifying language in several places. We've also updated the quality measures that are required to be collected by CCBHCs. And I'm going to go through now and provide a little bit more detail on each of those areas about the updates that we've made to the criteria. And then these are updates from the existing criteria, which were released in 2015, to the updated criteria that we just released last week. So I'm going to talk through these over the next set of slides, but just so you know, after that, I'm going to go back and talk about some of the updates that we made based on the public input that we received based on the draft criteria that we posted in December. So it's a little confusing, but I did want to talk a little bit about how this has changed since the last draft that we provided. The next couple slides focus on the broad changes from the existing criteria to the updated criteria. So in the areas of crisis care, we've required coordination with the 988 system, and especially the crisis center that's serving the area, the 988 crisis center that's serving the area that the CCBHC is in. We've updated crisis service requirements to align with SAMHSA's national guidelines around crisis services, including coordination with area air traffic control systems, and we have a definition for that in the criteria. That was a question we got last, based on the draft that we put out for public comment. And then we're also requiring that CCBHCs have some capacity for urgent care and walk-in during the hours that they're open. So if there's someone who's in crisis, the CCBHC should be able to provide them with a place to de-escalate that crisis and think about next steps. We've also tried to respond to the overdose epidemic in the new version of the criteria. CCBHCs must have addiction medicine staffing or consultation available in the new updated criteria. We've placed a stronger emphasis on the ability to prescribe buprenorphine and other medications for opioid use disorder, including coordination with opioid treatment programs if the CCBHC isn't an opioid treatment program. We've added provisions to strengthen the ability of CCBHCs to address overdose risk, similarly to how CCBHCs in the past have treated suicide risk. And then we've also included requirements for CCBHCs to provide access to naloxone for opioid overdose withdrawal reversal. We've also included a requirement to provide intensive outpatient services for substance use disorders in the new criteria, the updated criteria. We've required that the quality improvement plans that CCBHCs have to have in place address fatal and non-fatal overdoses. We've also required consultation with prescription drug monitoring or programs as a part of evaluation and prescribing in CCBHCs. And we've also added a focus on harm reduction as a part of the updated criteria. We've updated our training requirements to align with the National Culturally and Linguistically Appropriate Standards, or CLAS standards. We've included a stronger focus on outreach to underserved populations as required as a required activity. We required that quality improvement plans have an explicit focus on health disparities. So that includes racial and ethnic groups and sexual and gender minorities that experience health disparities. And we've also required that CCBHCs disaggregate data to track and improve outcomes for those populations that face health disparities. We've made other revisions to the criteria here. This isn't a comprehensive list of all the revisions. It's just some of the highlights on the next couple of slides. I wanted to share some of the more important updates that we've made. We've provided updated guidance on electronic health record and health information technology requirements in line with the most current regulations from the Office of the National Coordinator at HHS. We've changed requirements related to designated collaborating organizations and the provision of the 9 core services. So now designated collaborating organizations can provide any of the 9 required CCBHC services. But the CCBHC entity, the core CCBHC organization, has to provide a majority of the encounters across all of the 9 services, excluding crisis services. So that's not in each individual service category, that's across all of them, excluding crisis services. The CCBHC has to provide at least 51% of those encounters. We've required that CCBHCs be enrolled as a Medicaid provider of mental health and substance use disorder services. And we've adapted the criteria to apply to CCBHC expansion grants. When the 2015 criteria came out, the CCBHC expansion grant program didn't exist. So the criteria as they were before were really written only with Medicaid demonstration in mind. We've tried to increase flexibility and reduce burden in the model as well through the updated criteria. So we've increased some flexibility around the hiring of the medical director position. Previously, only CCBHCs in health professional shortage areas were able to recruit someone who wasn't a psychiatrist to be medical director after they've tried to try recruit a psychiatrist. We've broadened that to say that they can that this applies to all CCBHCs regardless of whether they're in the health professional shortage area. CCBHCs are still required to try and recruit a psychiatrist, but if they aren't able, they can recruit another prescriber that meets qualifications outlined in the criteria. We've relaxed our requirement around primary care involvement in treatment planning. We've relaxed the treatment plan update frequency. I know this is something that we got a lot of comments on over the years. Previously, CCBHCs had to update their treatment plans every 90 days. Now, the minimum requirement is to do it twice a year. We relaxed requirements around care coordination agreements. Previously, there was a long list of organizations that CCBHCs had to create care coordination agreements with, including their regional VA center. We've changed this so that instead of requiring that they have these agreements in place, they still have to try and establish the agreements. But if they're unable to establish the agreements, they can either set up joint protocols with those organizations as a first choice. And if they're unable to develop joint protocols that aren't signed, they can develop protocols just for the CCBHC and how they're going to coordinate with the required entities listed in the criteria. We've added some flexibility on the depth of assessment that CCBHCs have to engage in. They still have to address all the areas listed in the criteria, but they can choose to go into less depth in any of those areas based on the clinical judgment of the person administering the assessment. And so if someone, say, doesn't have any indication that they've got significant social determinant of health needs, then the clinician wouldn't have to necessarily go into as much depth in screening in that area, as an example of where they could streamline their approach to cut down on the burden of the model. We've also added language allowing CCBHCs to use recent evaluations from other trusted providers as a part of their evaluations of people being served, something we did based on the comments we received over the course of the last few months. We've included a process for CCBHCs or states to request approval of the use of a state-sanctioned crisis services as a designated collaborating organization to meet the crisis service requirements in the CCBHC model, even if those crisis services don't quite meet the standards laid out in the CCBHC criteria. And so this is important because we felt like we don't want CCBHCs developing parallel systems when there's a pretty good crisis service system already being developed by the state. There's a contact information in the criteria for people to send in those requests. We tried to make several additions to strengthen the model. So we tried to provide clear guidance around the community needs assessment. We included a stronger focus on shared decision-making and private client preferences of people being served throughout. We've added a requirement around assisting clients to access benefits and enroll in programs. We added additional detail around outpatient service requirements. We included more specificity around primary care screening and monitoring, including the requirement to screen for HIV and viral hepatitis. We've required provision of supports around employment and education, housing, and social inclusion and psychiatric rehabilitation. I will add one note here. There is a requirement to provide supported employment services, but clinics have a lot of flexibility in how they structure that. There isn't a requirement for a specific model such as IPS support individual placement and support employment. So the clinics and states have flexibility in how they can shape what their supported employment programs look like. We've recommended the use of, and I should say, we always recommend that people use evidence-based models, but we understand we wanted to provide people flexibility to develop their own programs as well. We've recommended the use of measurement-based care. We've added an additional focus on serious mental illness, serious emotional disturbances, and severe substance use disorders in the introduction. We felt it's important that CCBHCs focus on these populations that are more likely to be served through safety net and public systems that the CCBHCs are a part of. We've added language clarifying that treatment for tobacco use disorders is in the scope of outpatient services that are required. And then we've also encouraged but not required CCBHCs to become tobacco-free campuses. We've added language encouraging same-day and open access scheduling. We've also added language clarifying encouraging that services should be provided in community settings where possible and where it makes sense for the needs of the population being served. We've updated our language. Instead of saying consumer throughout, we refer to the people receiving services from CCBHCs as people receiving services, in line with a recommendation from several people. We've Taken out any references to detoxification and focused on the appropriate medical terminology of withdrawal management. We have taken out medication-assisted treatment throughout and used language around medications for opioid use disorders, alcohol use disorders, and tobacco use disorders. We've also updated our language around peers to try and make it, more applicable across the field of mental health and substance use. We've provided clarification around what should be included in the comprehensive screening and assessment. We've clarified our definition of targeted case management. We've also recommended that CCBHCs use intensive supports like assertive community treatment, although that's not a requirement. We've clarified requirements around representation of people with lived experience and their family members in governance. And we've removed a lot of explanatory language around HIPAA. There were several places in the criteria that went into some detail explaining the health insurance, the HIPAA, and we've decided that that language was more confusing than helpful. And if you need guidance around HIPAA, you should seek it out through the Office of Civil Rights at HHS. There's minor changes throughout to reflect clarifications to the original criteria in areas where stakeholders identified ambiguities. And so I want to talk now, that's a general overview of all the changes from the original criteria to the updated criteria. I'm now going to talk about changes we made specifically based on the feedback that we received on the draft criteria that we posted on December 21st. And you can see that some of these items are highlighted in blue. Those are areas that we changed, but I've already mentioned in the last section. So I'm not going to go through the ones that are highlighted in blue again, but I'm going to mention some of the other ones. These are changes that we've made based on the feedback that we received on the draft that was posted on December 21st. So we did clarify language in several places where people said the language was unclear without trying to make any substantive change in those areas. We added consistent language around telehealth and related technologies, which was in several sections throughout the criteria. We've simplified our terminology around evaluations and treatment planning. We clarified our language around crisis planning in a few places throughout the criteria. We required the development of protocols for transitions from residential and inpatient facilities serving children and youth, which weren't called out specifically. These are facilities like psychiatric residential treatment facilities. We added recording system involvement, such as child welfare and juvenile justice for children and youth served by the CCBHC as a part of the initial and comprehensive evaluation standards. We included more detail around the definition of psychiatric rehabilitation services, and we drew on the 2021 Medicaid state health official letter in the definition of social determinants of health to explain a little bit of the reasoning behind that and also explain how that kind of fits within the Medicaid program for those CCBHCs that aren't a part of the Medicaid demonstration. All right, let's see. All right. We have added language encouraging coaching and supervision related to evidence-based, evidence-informed, and promising practices. We have included provisions supporting the use of notifications around admission and discharge from inpatient facilities, something that's very important for care coordination. We've included a mention of the state option of using independent accrediting bodies as a part of the state CCBHC certification process. There was already language around this in the criteria. We just tried to make it clearer that states can use independent accrediting bodies as a part of their certification processes, if they so choose. We've added language around the timing of mobile crisis response timing. For those of you who reviewed the draft that we released in December 21st, we had encouraged state CCBHC programs to have a 2-hour response time in line with SAMHSA's national guidelines. We got a lot of feedback that wasn't realistic for some CCBHCs, so we've relaxed that to the previously existing standard of having a mobile crisis response within 3 hours. We amended our section around primary care screening and monitoring. We got a lot of comments on this, and so There were several people who felt that the language that we had in the version we released on December 21st would have required CCBHCs to develop in-house capacity around laboratory testing and to become CLIA certified. And so we've made this language broader. We've said that CCBHCs can fulfill this requirement through relationships with laboratory organizations or through coordination with primary care providers. We also updated requirements around the representation of people with lived experience in governance. There were some concerns that the previously framework released in December was unworkable, and so we've updated that somewhat, but still tried to make sure that CCBHCs have strong representation in their governance systems. We've added language to support coordination with other processes in states. So some states have special processes for determining level of care needs or for evaluation of children and youth through using tools such as the CANs or systems for determining level of care needs for people with intellectual or developmental disabilities. We don't want CCBHCs duplicating that kind of work, and so we wanted CCBHCs to take that into account and incorporate that into the work they're doing, coordinate with those processes instead of creating duplicative processes. We added language to give flexibility to provide ongoing services to people who transition frequently in and out of the CCBHC service area. So this isn't a requirement on CCBHCs, but there are populations that will go in and out of the service area, such as people who are experiencing homelessness, such as children and youth who may be involved in the child welfare system, or adults who may be involved in the criminal justice system experiencing incarceration. Who may cycle in and out of the service area. And so if CCBHCs want to try and figure out a way to have continuous services through telehealth or other means to do that, they can certainly try and do that. So we just wanted to make clear that that was an option that CCBHCs had. So that's really a broad overview of the changes that we made to the certification criteria. We also updated the quality measures, and the quality measures really, the required CCBHC quality measures, these stayed consistent from the December 21st draft to the draft that we just released last week. There was just one small change that I'll mention in a second. So in the updates to the quality measures, we are proposing now to have 5 clinic collected measures and 13 state collected measures. That's a slight reduction and a change from the previously required 9 clinic reported measures and 12 state reported measures. We strengthened the focus on time to service, on crisis service response, on social determinants of health, medications for opioid use disorders in these updated quality measures. We'll be using updated technical specifications for measures that were out of date in our current technical specifications, and we'll be also developing new technical specifications for some of the measures that are newly created for CCBHCs. We are also going to be removing or making optional some of the measures that were problematic. And so you can see the measures that are highlighted in green here on the right, or have little asterisks next to them. Those are measures that are new or significantly expanded. The other measures you see here were previously existing measures. The one measure that did change from December to now is a hemoglobin A1C control for patients with diabetes, and it wasn't a major change, but the data, the way that data is reported has been changed in the latest version of that measure, and we wanted to align with the latest version of that measure. So the core measure and data remains the same, just the way it's reported is a little different and the titles changed. But as I said, largely the updated measures stayed the same in this version of the criteria compared with the version we released in December. So what's the implementation timeline? I'm sure is a lot of you have on your mind for the updated criteria. We're not expecting you to have the updated criteria in place overnight. The new programs that are going to be joining as a result of the Bipartisan Safer Community Act expansion of the Medicaid demonstration will be expected to join with the new criteria. So those are the states that have received planning grants this last week and will be joining the demonstration on or after July 1st, 2024. They will be expected to join the demonstration using the updated criteria. All SAMHSA expansion grant recipients, all CCBHC expansion grant recipients will be expected to meet the updated certification criteria by July 1st, 2024. Any existing state CCBHC Section 223 demonstration programs, uses the Medicaid demonstration, are expected to come into compliance with the updated certification criteria by the start of the demonstration year, beginning on or after July 1st, 2024. Many of you may know that states have different demonstration years. Some start in July, one starts in October, one starts in January, another two start in April. So whenever the beginning of their next demonstration year is after July 1st, 2024 is when those state programs would be responsible for coming into compliance with the certification criteria. And there are some other state initiatives outside of the federal CCBHC programs that support CCBHCs. Those aren't, under our purview. They're independent state programs often, and we would encourage them to use the same timeline of July 1st, 2024 for trying to come into compliance with alignment with the new criteria. So that's generally the timelines for coming into adherence with the new criteria. I will note we are not going to hold any state or any individual CCBHC, no CCBHC state or state is going to get in trouble for shifting to the new criteria sooner. There are some places where the new criteria have relaxed requirements. So if you move to those new requirements before July 1st, 2024, that's not going to result in any adverse action from the federal level in terms of the demonstration or the CCBHC expansion grants. So the sooner you want to move to the new criteria, the better. There'll be no penalties because of people moving to the updated criteria. And I should say, if state programs have different rules, it's really up to the individual state. That's the federal approach. So the updated criteria and a summary of the changes are available online on the SAMHSA website at this link you see on the screen right now. We are going to be posting a redline version and an updated checklist. Many of you are aware we have kind of a CCBHC certification criteria checklist that we've made available. We're going to be posting an updated version of that on our website soon, along with the redline version of the criteria that shows the changes from the original criteria, the 2015 criteria, to these updated criteria, trying to make the lives of all your compliance officers a little bit better as they wade through this process. And we are also going to be, over the next few months, making updates to our website and to the existing guidance, which is largely on the website, which is largely geared around the existing criteria. But we have a lot of work to do to update our guidance in other areas as well. So I did want to say thank you, first of all, to all of you, who are on the phone today. I see a few familiar faces and names and the participants. We've just been overwhelmed. Well, not overwhelmed. We've been very thankful for all the feedback we've gotten throughout the process and through the continual engagement, for your continual engagement. So thank you to all the folks in states, all the stakeholders, all the national organizations, all the individuals, all the folks receiving services, the experts, the researchers, you name it. All of you participated in this process. We really appreciate it. I think we have improved the criteria, and largely because of your input and help. So thank you to all of you. But I do also have to thank a number of individuals who have really thrown a lot of their time, their weekends, their blood, sweat, and occasionally tears into the process of updating the criteria. And so there are several groups of people who really made substantial contributions. We were lucky to have very strong support from a team at Westat. And so I just want to thank Shoma Ghosh, who led that effort, just a great person to work with. And I apologize if I mispronounce any of your names, but Phil Mazakowski, Robin Ritter, Abita Hendrickson, and Finn Teach. And they also worked with David Morissette, a consultant on this effort. David, for those of you who don't know, was a longtime SAMHSA employee before retiring from the Public Health Service. He was substantially involved in creating the original criteria and getting the whole CCBHC initiative off the ground, and now he took another deep dive. It is not very successful retirement into these criteria. So thanks to David for the many hours he spent on the criteria and over the past few months, on travel, on weekends, etc. I want to thank our team at SAMHSA, Mary Blake, David Berry, Lila DeSola, Alfred Jackson, Peggy O'Brien, Belina Shaw, and then the leadership of our center director, Anita Everett, Dr. Anita Everett, who really made all this possible and also provided some invaluable insight and guidance as we went through the process. I also really want to thank our federal partners. We are been blessed to be able to work with a really great group of folks, not just on the criteria, but really on everything related to CCBHCs. And I just want to thank Beverly Boston, Danielle Motley, and Kirsten Peronio at CMS, Laura Jacobus Canner, and Judy Day over at the Office of the Assistant Secretary for Planning and Evaluation. But once again, thanks to everybody in the field who contributed. And this that's the end of my kind of formal remarks today. But looks like we have about 15 minutes for questions, so we'll shift over to questions here. And
Sure.
I think what we're going to try and do here is have David Berry, one of my compatriots, try and field questions from the chat, so we'll go from there. So.
David, I've been collecting the questions as they come in. So the first question would be, and this seems to be the most common one, will there be a copy of the PowerPoint?
Yes, we'll post a version of this PowerPoint up on our website. And a recording. I think I'll link to the recording as well.
Is this the
The next
SAMHSA
question.
website you're listening to?
Yeah, it'll be up on the SAMHSA website, the CCBHC website. Actually, if you go back to that last slide, it'll be linked off of
I
this.
can't see the slide. That's why I asked.
It'll be
Okay,
on SAMHSA.gov CCBHCs. You could it'll be.
Yeah, if you Google SAMHSA CCBHC, it's one of the first things to come up. It's the CCBHC page on the SAMHSA website.
Thank you.
Sure.
David, the next question is, our state changed the regulations and now require treatment plans to be updated at least once per year. Should we follow our state regulations if they differ from the criteria?
No, so the criteria provide a floor. States are always welcome to go beyond the CCBHC criteria to provide stricter requirements, but the CCBHC criteria requirements do provide a floor. So if you're a CCBHC, the expectation will be that you provide that update, within the, in accordance with the criteria, which is, twice a year.
So the next question is, when do you say you would be sending out the specifications for the clinic collected measures?
We're going to be developing those over the next few months and disseminating them. We are going to also be releasing timeframes for coming into compliance with the new measures, and that those timeframes are going to be a little bit different from the timeframes for the rest of the criteria. But we know it's a heavy lift to change those systems, and so we're definitely going to be mindful of that as we release those timeframes.
The next question is, is adult BMI still a required quality measure?
I believe that one was taken out or made optional. We got a lot of feedback around that one, and so my memory serves me, which is not a very reliable thing. I think we took that one out. So.
And has SAMHSA cross-checked billability of the required quality measures at the state level and at the CMS level?
Of the quality measures?
I think this is, yes. So
the quality measures, we tried to use quality measures that were, in the CMS core measure set. In some cases we have specific CCBHC measures, but we tried to do this in a way that the quality measures would, align with current efforts.
So next question is, in reference to the significant changes to evaluations and outcome measure requirements in 4.d, will the new RFP other funding or upgraded tech systems to accommodate these new measures? So I think what they're asking is, will there be other opportunities to be able to have upgraded tech systems to meet these requirements? So
4.d, I believe that's around the kind of the evaluation, for treatment planning, et cetera. And so that is certainly an allowable expense under our SAMHSA expansion grants. So certainly something that if people want to update their systems, that's a completely valid use of SAMHSA grant funding. You can include that in your original grant applications, and if you need to make adjustments to your grant plan, that's the kind of thing you can work with your government project officer on if you're a SAMHSA expansion grant. Conducting those evaluations would be kind of an allowable service. It's one of the 9 required services under the Medicaid demonstration, so that would be a CCBHC billable service. As far as the updates to the systems, I think that's a different question. We can try and answer questions on that. You should kind of try and filter those questions through your state if you have questions about billability in the demonstration. But I think that's kind of where we stand with that question.
Yep. And so the next question has to deal with governance. Can you provide some clarification as to the definition of governance as noted by the criteria or SAMHSA standards? And they also want to know to what degree are meeting minutes required, and to whom is the governance board need to be reviewed by or approved by? They ask, does SAMHSA need to review the minutes? And does the organization have to review their minutes?
So I'd refer you back to the language in the criteria. CCBHC generally have to be nonprofits, which have separate board requirements. Unless they're part of government agencies, they have to have separate board requirements required as being a part of a nonprofit. If we don't specify anything about meeting minutes in the criteria, we don't have any requirement that. I can almost guarantee you that, we really want good conversations to happen in your board meetings. No one at SAMHSA is going to be reviewing your board meeting minutes. So, but what we want to see is representation of people being served, of people with lived experience of mental and substance use disorders, and then family members in governance. And so that is, if you have a board, having people from those populations on the board, one way to fulfill those requirements is to have a board that is comprised of at least 51% of people from those populations. Then there's a second option that has requirements or that have a little bit more specificity if you have an advisory council or some other method of meeting the governance requirements. But there's extra requirements to do that if you can't meet that 51% threshold. And as far as the definition of governance, there's no definition outside of what's comprised in the criteria, but generally it's kind of the administrative functions that govern how the CCBHC runs is what we mean by governance. We want to have meaningful input from the people being served and how CCBHCs run. At the end of the day, it's their lives. That's why we're all here, and we want their input and how to shape the services we're providing across the CCBHC initiative.
Thank you, David. The next question, there's a lot of different questions asking about the timeline of when they have to adopt the CCBHC criteria. I'm throwing the timeline page into the chat. I don't know if there's anything else you wanted to add about the timeline.
I can run through it one more time real quick. And so generally the date people should have in mind is July 1st, 2024, and that's the requirement for SAMHSA's expansion grant. So if you're a current expansion grant, that's when you're going to have to be in compliant with the new criteria. If you are an existing grant that's applying for the innovation and advancement track for existing CCBHCs at the end of this year, and you're hoping to get a grant at the end of this year, you're going to be responsible for complying with the criteria by July 1st, 2024. If you are applying for a CCBHC planning, development, and implementation grant, a PDI grant, and you're hoping to get funded at the end of this year, you won't have to comply with the criteria until the end of your first grant year, which would be next September, and that'll be after July 1st, 2024. So you would have to comply with the updated criteria at that point. For CCBHCs participating in state demonstration programs, it's up to the state how they want to do this, but generally the state's required to come into compliance with the updated criteria by the beginning of the demonstration year starting on or after July 1st, 2024. And then there's these independent state programs in places like Kansas and Texas, and they're run through separate authorities. And we'd encourage them to come into compliance with new criteria again around July 1st, 2024. So I think those are the timelines. Sorry if I missed any of the permutations of CCBHCs, but July 1st, 2024 is the date in general when most CCBHCs should be coming into compliance.
Thank you, David. The next question is seems a common one as well, and I think it's one that we definitely want to address. Can you speak to a little bit more about what it means for the CCBHC to be providing 51% of the services?
Yeah, and so this is an area where we got a lot of comments, based on the draft we put out in December 21st. So the language we had included at that point was the majority of services provided, and people said, we need a more specific definition. And so the more specific definition that we're providing in the updated criteria is the CCBHC organization. So that's the organization separate from any designated collaborating organization. That core organization that is the CCBHC has to directly provide. So that's either through their direct or contracted staff that are managed as a part of the CCBHC, they have to directly provide 51% of the encounters across the 9 services, the 9 required services, excluding crisis services. And that's all those services taken as a whole, not within each individual service category. So the CCBHC has to provide a majority of the services across the 9 services. So I hope that's clear. The reason we did that is we had a previous requirement that the CCBHC had to provide directly 4 of the 9 services. After looking at the statute, our general counsel within HHS determined we couldn't make that requirement anymore. We still wanted the core CCBHC organization to provide a core set of services. We didn't want the CCBHC just to be a pass-through, because if they were just passing through to other providers, we felt like that would not enable the CCBHC to provide the comprehensive coordinated services that CCBHCs are supposed to provide, the whole point of the model. And so that's why we've added this requirement that they provide the majority of services directly. And again, the measurement there is 51% or more of the encounters across the 9 services, excluding crisis services.
And the next question has to go, is there is a new provision that allows CCBHCs to request approval from HHS to use certain state-sanctioned crisis systems. Is approval now needed anytime a CCBHC uses a state-sanctioned system, or only certain types of state-sanctioned systems?
No. So if there's a state-sanctioned system and it meets the CCBHC certification criteria requirements, you don't need to check with us. It's fine. Please use that state system. We don't want you to build a duplicative system. We want you to coordinate with what states are going to develop crisis systems. If there's a state-sanctioned system that does not meet the certification criteria standards, the standards aren't too extensive, but they do have a requirement around a 3-hour crisis response, and there is a requirement for 24/7 coverage for mobile crisis response. But if there is a state system that doesn't meet what's outlined in the criteria in some way, you can come to us and say, our system doesn't quite meet this standard. Is it okay for us to still have a designated collaborating organization relationship with them to fulfill the crisis service requirement? An example I might use, we're going to look at every case individually and whether we think it's okay, but say there's a state with a large frontier area, and they cannot keep a mobile crisis team staffed between the hours of 12 o'clock a.m. and 4 o'clock a.m. On weekdays, or on Monday through Thursday. It's just not feasible for them to do that. They're not getting the call volume, and during those hours they have a backup system through their call centers and through their other emergency response systems to ensure some kind of adequate crisis response. That's the kind of thing we might look at and see, like, okay, that doesn't strictly meet the certification criteria requirements, but we understand that given the constraints the system has, why they've done that, and we don't want to require the CCBHC to create a separate crisis system from the one the state is building, because there's a slight difference in the requirements, and a reasonable difference. And so that's why we've included this provision. You don't have to come in to us if the state crisis system meets the certification criteria requirements, but if there are minor differences like that that are understandable, those are the kinds of situations we might look at and say, okay, that's reasonable. They're not quite meeting the certification criteria requirements, but we understand why, and maybe we'd grant that to be okay place to do a DCO. If a state was to come to us to say, we don't really want to set up or if a CCBHC was to come to us and say, we don't really, have the capacity to set up a mobile crisis response, and there's no existing system. What we want to do is have a co-responder with the local police during business hours to fulfill the mobile crisis requirements. That's the case where we would probably say, well, that is not a 24/7 mobile crisis response, that we want to see. It's going to be on a case-by-case basis. But we want to make sure that we're building good crisis systems that aren't duplicative of existing systems.
David, I think we have time for just one more, but I think
Okay.
This is one that I think people may be wanting to just a little clarification on. Why have a DCO if you need to provide most of all the services? This would seem to discourage collaborative relationships.
There's lots of reasons to have a DCO. You can DC out at any of the 9 services. You know, and there may be DCOs that are, you know, the ability to provide quality services and specialize with a certain population or intervention, you know, that you would want to work with. It may just be a question of trying to create the adequate capacity to reach your entire community. So you might want to partner with other organizations as DCOs. It's just that the CCBHC needs to ensure that DCO provided services are coordinated and they're meeting the standards set out in the certification criteria. So there's lots of good reasons to use the DCO relationship to provide the CCBHC service package. Again, CCBHCs have to provide 51% across the 9 services. That doesn't to say they have to all provide all the 9 services directly. They just have to provide the majority of the services across the 9 services in terms of service volume as measured by encounters.
Thank you, David. We're at the top of the hour. I'm collecting all the extra questions that have been put into the chat so we can include in a future FAQ.
Yeah, and I saw there was a comment in the chat about an FAQ. That's something we're going to work on. So, you know, thanks again for all your engagement and for your time today. I hope this was helpful, and I look forward to working with you in the future. Thanks, everybody.